Hello, thanks for joining us. I'm Andrew Mackenzie, Chief Science Officer at Arbital Health and a Value-Based Care Actuary. I'm joined with one of the clients that I work with on a frequent basis. I have the pleasure working with Matthew Scalo. Matt, you want to introduce yourself?
Yeah, thanks, Andrew. My name is Matt Scalo. I'm the Chief Financial Officer at Podimetrics. We are a organization that focuses on the complex diabetic patient that has a signature condition of diabetic foot ulcer. We've been in partnership with the team at Arbital for a few years now, and they have been an incredible resource for us as we've continued to partner with health plans across the country through value-based care arrangements to try and treat this patient population in a way that is economically viable for not only the health system, but that also enables us to deliver care to the patient population and expanding patient populations over time.
We'd love to just learn a little more about what Podimetrics is seen as some of the biggest challenges in the industry. What are some of the things that you've been dealing with directly, and maybe what led you to start an engagement with Arbital a year ago, and how that's maybe proven to be valuable to Podimetrics?
Yeah, thanks, Andrew. Here at Podi, we try and focus on providing meaningful care for the complex diabetic patient that will typically present with a signature condition of diabetic foot ulcer. The CDC reports that there's roughly 37 million Americans that have diabetes, 90 to 95% of type 2 diabetes, and this problem's getting worse. We find that the specific patient that we focus on today is roughly 5% of the diabetes patient population, but drives roughly 30% of the cost. And that's where we're primarily focused in order to try and drive better outcomes for patients and better outcomes for payers alike.
So can you tell us a little more about how Podimetrics is impacting this 5% of the population that's driving 30% of the cost?
Sure. We have an FDA-cleared program that includes an in-home device and a wraparound clinical support program. Patients step on our device for about 20 seconds a day, and we have data that will be kind of transmitted up to our organization, and we'll have a clinical support team that will engage patients as we're seeing temperature asymmetry or shifts in utilization of the device to make sure that they are they've got good health in general, and to the extent that there are shifts in their health, we can help coordinate access to the care management teams within health plans that then further coordinate access for that patient to a provider to have them seen. So we really serve as a kind of a navigator of sorts. We embed ourselves deeply into the care management programs of health plans in order to make sure those patients are getting access to providers and the healthcare that they need when they need it.
Yeah, excellent. And maybe for some of the audience who's not that familiar with diabetic foot ulcers, what happens to members if they are left untreated, or what happens kind of as the foot ulcer progresses? We've talked about costs being very high, but I think there's also a big quality of life impact too. So what would happen if you can't detect foot ulcer, and then when you do detect a foot ulcer early, how is that providing value to the member and to the system?
Yeah, it's a great question. This patient is oftentimes considered highly comorbid. On average, they have roughly 4.5 comorbidities. So they've got other conditions in their system that they're dealing with, typically, CKD or CHF, other comorbidities that are fairly significant. And typically what happens is as a diabetic foot ulcer emerges, it's sort of an inflammatory bomb. It's at least the way we kind of talk about it internally, which is an indicator of something else happening more significantly in the system. By early detecting diabetic foot ulcers, and our product does it as a thermometry solution, we are able to really get ahead of the broader chronic issue that patient may end up ultimately having, an ER utilization or other, system utilization, get them the treatment ahead of a chronic episode. One of the other big components, obviously a diabetic foot ulcer ends up being an open wound on the bottom of your foot, oftentimes really hard to close, never really gets 100% better, typically will lead to, a partial foot amputation or other amputations. And as a patient, has an amputation, their risk for death actually increases pretty significantly post. So our goal is to try and eliminate as many foot ulcers as possible, because that eliminates amputations, and by eliminating amputations, we end up eliminating, a big portion of death.
Yeah. As type 1 diabetic myself, I've always been very concerned about the greatest consequences of diabetes being loss of limb, amputation, blindness. And so we're always educated around keeping your blood sugar control, trying to do prevention. But I feel like there's not a huge amount of solutions in the market that are really looking at how do we get in front of escalation of events like this. So it's just really powerful to me to see a technology that's trying to get in front of something that could lead to an amputation. What's been your success at getting mats in front of the right people? And maybe what are some of the challenges that you faced in the market as you try to bring your technology to the market?
Yeah, great question. One of the bigger challenges is just awareness of the program. So having worked in a health plan in the past, oftentimes health plan actuaries will look at diabetes as a category, not specifically the chronic comorbid patient that suffers from DFU, the one that we really try and treat. And there's not a single CPT code that drives people to exactly this patient. We have to look across more than 200 CPT codes through claims and utilization history to try and identify the patient. And again, as you think about health plans, they're oftentimes trying to implement programs for the category in total, not necessarily the subcategories within the diabetes population. So that 5% population will oftentimes not rise to a level of significance that they are squarely focused on this as a problem on their own, until we come in with the support of Arbital Health to highlight what we're seeing in terms of utilization and costs that the health plan is incurring as a result of this relatively small population, but their outsized impact on cost in the system. In addition to that, the device itself is pretty easy to use. We find high satisfaction. We've got high engagement with this patient population, and they are largely very adherent. So once we get a device into someone's home, a significant portion of that population will utilize the device and continue to utilize it on an ongoing basis, which is often a challenge that we have with this patient population. The health system will refer to them as kind of the poorly compliant patient, because you usually can't get in front of them. And then when you do, you can't get them to take their medication or follow kind of the protocol that their providers may be suggesting. But based on the ease of use that we've created and in connecting with them when we see an issue, they seem to be more adherent. And then providers alike, we're not an RPM solution. We are a kind of an integrated component of the care management system. So we really engage well with providers, because we're not another board that they need to keep an eye on, or another report. We tell a provider when a patient of theirs has an issue and they need to be seen. And oftentimes that helps eliminate the other higher cost utilizations or potential amputations if this patient was left untreated or unchecked.
So I think I heard 5 different challenges and a few solutions to those challenges. So I'll group them into three areas. You've got payer or plan challenges with awareness and adoption, member and provider level, and that's a lot to navigate, the payer, member, and the provider. So on the payer side, it sounded like there's a lack of awareness of who this population is, the size of it, and they tend to think about diabetes more holistically than diabetic foot ulcers. Then you have the economic awareness of what's really the economics here and how much are they driving. So you mentioned that these members are driving 30% of the spend, but since only 5% of the population, it can be difficult for a plan to interpret the 5% of the diabetic population. Now we're talking about 1 to 2% of the population as potentially being a problem. Yet I think in general, there is acute awareness about a low percentage of the population driving a huge amount of spend. But a big problem I think that exists in the industry is reacting to an issue after it's happened rather than preventing the issue before it occurs. And that leads to the third issue here, which is, well, how do you identify those 5% of patients ahead of time? So we'll come back to those 3 issues in a minute. The member issue, it can be difficult to engage members. I think you're saying the Podimetrics solution is really easy to use. It's a mat, people step on it, it automatically reads. There's like not much of a hassle to do member level integration, and you get really high adoption rates. And then the provider issue, you've got to be able to integrate seamlessly with the providers, endocrinologists, PCPs. And it sounds like Podimetrics has a really good system set up on that. So I want to return to kind of like the payer pain points and how Arbital's been helping you in those areas. So again, there's 3 pain points that I think I heard you talking about, Matt, were awareness of the problem, the economics of the problem, and then getting in front of the right patients at the right time before the foot ulcers are really developing and getting to the stage where they need aggressive treatment, they need emergency room visits, they need inpatient stays, and ultimately, hopefully, avoidably, they need amputations that could have been prevented if we had gotten the mat to them and monitoring technology to them in an appropriate amount of time.
So Podimetrics has worked pretty closely with Arbital to help better frame for health plans the size of the problem and how we identify the patient population that we would want to target. In doing so, we've worked collectively to build fairly complex, actuarial models that leverage historical claims data, looking at patient utilization over time across, as I said previously, more than 200 CPT codes. Given the comorbidity of this patient, they don't neatly fit into a box, so there's a lot of effort and energy that goes into that patient identification. Once we've got an understanding of what the kind of the trended costs of the patient population is over time, we'll work with payers to basically get our program in front of that patient in order to try and help drive that cost down. And we believe and have data that supports our ability to reduce utilization for services based on early identification and prevention of diabetic foot ulcers and complex complications that come with diabetes relative to just general treatment, which is how the system typically approaches these types of problems. So much so that we're willing to take risk on the patient population that we're serving. And Arbital has helped us really get comfortable in the different levels of risk that we can take across the different types of patient populations that we support. And we support all patient populations from Medicaid through commercial. They all have different profiles. And the work that the Arbital team does in conjunction with Podimetrics really gives us the confidence to continue to try and engage payers to continue to try and treat the patient, the complex diabetic patient that's struggling with diabetic foot ulcer.
So that's a great point, Matt. So going back to kind of one of the major pain points of payer interest, payer adoption, given that this is something that most plans don't fully have their arms wrapped around the DFU problem, the size of the DFU problem, that potentially makes them a little bit more averse to adoption because they don't have an existing system around, hey, let's put in a solution here. How has being open to taking risk, how has that kind of maybe changed some of the payer interest or the payer narrative versus maybe a more traditional non-risk-based financial arrangement?
Yeah, I mean, the historical healthcare system was largely fee-for-service based and was utilization based for providers, right? So providers got paid based on the number of services that they provided. And I think in part that led to some outsized increases in healthcare costs. And as the market continues to shift to more of a value-based arrangement, payers are looking for partners to basically take risk on the programs that they're putting in place to try and drive towards aligned outcomes and aligned incentives, right? So, as a way to try and manage the cost of care delivery for the member population that payers support, they're looking for partners that are willing to share in some of that risk. And then I also think it drives to better overall programs, right? So instead of having partners that can kind of come in or vendors really is what it turns into. Vendors that come in that are selling widgets or making outsized comments and suggestions as to what they can deliver to the health plan and to the patient without that value-based care kind of incentive and arrangement. you get a partner that is uniquely tied to the overall performance of the program. And from my perspective, we are focused more on the patient outcome aspect of things. I truly believe, as an organization, if we continue to deliver great patient outcomes, the rest of the value-based equation comes together perfectly. It's just a mechanism for us to shortcut some of the conversations that others may typically have where they're trying to sell in a service without actually making commitments to what they can deliver.
So I think part of what I'm hearing you say is that patient outcomes and quality outcomes matter the most, and that's what value-based care is all about. However, there's also just this core economic problem that exists. We really need to be efficient with the deployment of our resources, and if you can prove that a program both increases patient outcomes, like reducing amputations, while also producing financial value, like also reducing amputations, that's a win-win and an argument that any insurance company should say, okay, that makes sense. You're going to offload my risk, you're going to improve patient outcomes, and I can believe that. So that's a winning formula in a lot of ways. How have you been kind of progressing over time towards being able to tell that story better, and maybe what are some of the challenges that you've faced, that you've overcome, or maybe some of the challenges kind of you're still facing? And you talked a little bit about this earlier in terms of how Arbital's assisting with some of that, but maybe you could go into a little more detail on some of those aspects, Matt.
Yeah, I mean, we've been able to overcome some of the challenges with health plans in terms of their interest in partnering with Podimetrics just through data, right? Data and our commitment to deliver meaningful care at a meaningful return on investment for the health plan, right? They are bombarded with different partner opportunities. Prioritization sometimes becomes a challenge as they're looking across a large member population, trying to treat all the members as best they can. The engagement we've built and relationship we've built with Arbital has really allowed us to hone in on and clearly articulate what we see as the opportunity for Podimetrics to help that payer deliver better care to their patients and deliver better outcomes for both the payer and the patient. The work that's done in building the actuarial models to identify risk, the predictive modeling that we've used to identify the patient population, our ability to pretty cleanly predict what we see as resource utilization reductions across different categories of this complex and chronic diabetic patient. And then actually deliver the outcomes through the follow-on reporting once the program is in place. So we work very closely with the Arbital team to measure our outcomes. I think has created a level of transparency and comfort at the health plan level that we haven't seen previously, and we certainly weren't able to get to on our own prior to the relationship. Arbital's helped us with some of the early wins. I mean, most would say you get a payer sale and that leads to additional payer sales, right? They sort of follow what others are doing. And we've seen an increase in momentum in our interactions with payers and their interest in our program as a result of some of the outcomes we've been able to deliver with other payers and then communicate more broadly as example cases with actual payer data for similar patient populations that payers start to that increases the believability and the likelihood that a partnership would materialize as a result. And Arbital's been critical to helping us tell that story.
Great. I really appreciate that overview and the feedback. So a key thing I think I heard you mention was data being the biggest underpinnings of being able to translate into payer belief about results, as well as the fact of being able to measure results for other groups and really track actual outcomes, and then use that to really empower kind of the next sale. So I think a big mission at Arbital is letting data and appropriate interpretations of data tell the right story about what's the size of a problem, how do you actually measure if something's effective or not, and then how do you actually track, monitor results in real time and report real ROI. And then the next question is, well, how do we improve ROI? And then you hit on it as well. That's where we get into some of the predictive modeling. So in this case, how do we get in front of that right 5% of patients before the event, rather than just reacting to an event that's already happened. Arbital's big goal is to really empower solutions that work, like Podimetrics, to figure out how do we tell our story better using national data, using client data. How do we track what's working and what's not working? And then really, how do we optimize that for optimal solution to make the program as effective as possible and to be able to tell their story well to payers and to medical economics and actuarial teams at payers who are just saying, well, patient outcomes are good, but I really need to see that there's financial value here because I'm an insurer, I need to make money. So we really enjoy partnering with companies like Podimetrics, where we can bring on kind of the economic lens to a clinical solution that's already working very well, and really provide transparency into what does the data actually tell us about how the program's working and how it could be working better, at least from a financial perspective.
Yeah, we very much appreciate the relationship. Our ability to engage patients is driven by our ability to partner with health plans, and our ability to partner with health plans has only increased as a result of the relationship that we built. And I've seen that as we learn more, we continue to refine our offering to sharpen kind of what our message to payers is, and with precision deliver meaningful outcomes, both economically, as you had mentioned, but then also our North Star is providing incredible patient care. And as I said previously, if we're delivering great patient care, the rest of it sort of falls out, and the data is actually starting to prove some of that.
If you feel like, Matt, you've seen much of a change over the last several years, 5 years or so, in terms of payer focus or maybe nature of some of the responses you've gotten. I think you talked a lot about how data has enabled better conversations and you've gotten more comfortable with the ability to take risk, and that's kind of pivoted some of those conversations materially. But do you think you would have good commentary on kind of any evolution, or is that something we don't need to talk about?
We could talk about, I think the industry as a whole is transitioning more to value-based arrangements as they're trying to better manage healthcare costs over time, and they're looking for partners that are willing to engage in some kind of risk-sharing arrangement in order to treat the patient population more effectively and at a more economically sustainable cost. And I think value-based care is the lever right now. Was previously kind of an opaque term that most people really didn't understand, but as data and has come to bear, and organizations like Arbital have started to partner with provider groups or other healthcare partners to health plans, we've really been able to lever value-based care arrangements in order to align incentives with both organizations while keeping patient care kind of the North Star for both orgs.
And what do you think is some of the factors driving some of this transformation?
Yeah, I think personally, you look at healthcare costs, and it's continuing to increase, and it's increasing at an unsustainable rate. And health plans are largely challenged with trying to figure out how to continue to support patient populations with the amount of premium dollars that they bring in. And one way of doing that is to ensure that you've got the right partners driving towards appropriate outcomes versus just being incremental costs to the system through the more traditional fee-for-service arrangements. And in order for partners to engage with health plans and patients through value-based care arrangements, leveraging that data to understand what the risks and opportunities are to deliver a more effective, economically effective level of care, you need the support. You need to know how to do that. We've continued to partner with Arbital in ways to ensure that we are at or ahead of the curve and trying to predict what we see as kind of the next evolution in kind of the value-based care arrangements and in how we engage payers.
Thanks for your time today, Matt. Just to quickly summarize, I think some of the key takeaways that I'm hearing. Podimetrics has an excellent preventative clinical solution to get smart mats in front of high-risk diabetics of developing foot ulcers that could ultimately lead to amputation and even a loss of life. And being able to get in front of that is just a huge technology and clinical advance in the medical community. But unfortunately, one of the big challenges we have with access and deployment of that is how do we convince payers that they should spend some energy, spend some money, and adopt a program like this. That's really where the role of Arbital has provided an accelerant to Podimetrics to help with data, tell the story in terms of the size of the problem a bit better, measure outcomes, and design a way to accurately measure outcomes in a way that payers can understand and can really get you to the right answer. And then ultimately to help increase program effectiveness by helping target the patients most at risk to develop foot ulcers through the use of machine learning. So that's kind of my point of view on how we've been partnering and some of the conclusions I'm hearing from the conversation today. Anything to add to that, Matt, in conclusion?
No, I mean, just to highlight our ability to do the strong work we do in the space, treating this patient is largely supercharged by the relationship that we've developed with Arbital over time. The expertise and the precision that you bring to our organization through the modeling that you've done, the predictive work that we've done to help identify the patients is second to none. And I'm looking forward to a continued and growing relationship as we continue to try and to make good headway against this debilitating issue for a growing percentage of the population.
Excellent. Thank you, Matt.
Thanks, Andrew.